Hello, everyone, and welcome to the fourth episode of Cognition Conversations. I'm Tony Caggiano, Chief Medical Officer at Cognition Therapeutics. Today, we have a two-part conversation about dementia with Lewy body. We're fortunate to be joined today by several neuroscience thought leaders active in Lewy body dementia research. I'd like to introduce and welcome first Dr. Sarah Berman, Professor of Neurology at the University of Pittsburgh School of Medicine. Dr. James Leverins, who is director of the Cleveland Lou Ruvo Center for Brain Health, and finally, Dr. David Sprecher, who is movement disorder director from Banner Sun Health Research Institute in Arizona. Moderating our discussion will be Dr. Brendan Kelly. Brendan is professor of neurology at the University of Texas Southwestern Medical Center. Brendan, perhaps you can start our discussion today by framing some of the issues you see in conducting DLB research.
Absolutely. Well, thank you for getting us all together for this conversation, and hope that we can draw some much needed attention to dementia with Lewy bodies. For anybody who's watching that may be less familiar with that condition, dementia with Lewy bodies is the second most common neurodegenerative cause for dementia in older adults, and it's estimated that it affects somewhere between 1.2 and 1.4 million Americans. So it's not an uncommon disease, and yet it has not really garnered the type of research attention and research focus that Alzheimer's disease has. Alzheimer's disease and dementia with Lewy bodies are not mutually exclusive, and those pathologies may overlap even within the same patient. Jim, maybe you could comment on how often in your clinical practice you feel that you're seeing patients that have purely dementia with Lewy bodies or purely Alzheimer's, and how many times you may consider that those two pathologies are overlapping in the patient.
Sure, thank you. We know clinically in terms of our evaluations that probably about 50% of dementia with Lewy body cases, people who present with a dementia with Lewy body clinical syndrome, that probably about 50% have coexistent Alzheimer changes in terms of what we can do with an amyloid plaque image, for example. But we know that almost all have some amyloid deposition in their brains. Similarly, if you look at Alzheimer's disease, that patients and individuals who've come to autopsy, about 50% have some kind of Lewy body pathology that we link to Lewy body dementia. So a lot of overlap pathologically and clinically. It can be a challenge.
Sarah, for those who are watching that may be a little less familiar with the pathology substrates of dementia with Lewy bodies and Alzheimer's disease, maybe you could remind our audience of what we mean when we're talking about Alzheimer's pathology or Lewy body pathology.
So with Lewy body pathology, we're talking about a certain type of protein that builds up in the brain, and that protein is called alpha-synuclein. So we call those synucleinopathies because they build up synuclein. Alzheimer's disease has other proteins that build up called amyloid and tau, and they form certain pathological changes in the brain. And so what we're talking about in distinguishing them is that often people who clinically have Lewy body dementia or dementia with Lewy bodies, they have that synuclein in their brain, but if you look in their brain, they also have those changes that you see in Alzheimer's disease. And because of that, clinically, they really overlap also.
Thank you for that explanation, and I think that really kind of nicely intersects with a question I'm hoping maybe David might start a little conversation about, which is, what do you think is the role of amyloid PET scans? Like for example, if a person had a negative amyloid PET scan or a positive one, how does that help us to sort out about Lewy body pathology?
Yeah, well, this video is being recorded at a very pivotal time where treatments are becoming available for Alzheimer's disease, where these very expensive PET scans are going to be critical to confirming people actually have amyloid pathology in the brain and are appropriate for that treatment. One of the big challenges is these are still very expensive biomarkers to confirm amyloid pathology, and it's also still unclear in patients who have pure Lewy body as opposed to mixed Lewy body plus amyloid pathology, whether a particular treatment that we're testing will work differently in someone with pure pathology versus mixed.
David, how do you feel that incorporating these biomarkers as we look to, let's say that we've designed a clinical research study for dementia with Lewy bodies, how might we use these biomarkers to ensure that we're studying patients that have the disease that we think we're studying?
So in the study of Lewy body dementia, so specifically dementia with Lewy bodies here, there are two main important challenges. First of all, there are patients that have subtle features that don't necessarily meet all the classic clinical criteria for dementia with Lewy bodies. I don't think we're ready to modify our criterion trials just yet and let biomarkers supplant those clinical criteria. But there are cases where people do have some subtle features that suggest dementia with Lewy bodies, subtle motor features of Parkinsonism, subtle fluctuations in cognition, rare visual hallucinations. Movements during sleep, we're not really sure that these are truly dream enactment behaviors. And we already know that in these patients with mixed pathology, when there's a lot of amyloid pathology or amyloid and tau of Alzheimer's, may mask some of those dementia with Lewy body features. So if we could validate imaging, CSF, or skin biomarkers to improve our diagnostic accuracy and confidence, it would speed recruitment for these trials.
Let's say that now you put on your clinician's hat for a second and you say, I have this patient who has these subtle findings, perhaps clinically not enough that you feel absolutely confident that you're dealing with dementia with Lewy bodies. How might you use existing biomarkers to try to understand, are these early symptoms of that, or is this person, progressing along towards Alzheimer's disease, or do I just need to, kind of continue to follow this person clinically to see how their symptoms emerge?
One important thing to point out is that if a DAT scan is abnormal, or if the polysomnogram shows REM sleep without atonia, then we have one or both biomarkers that we can then use along with one or more of those core clinical features. And then we can be confident that we have that sensitivity and specificity confirmed from our current criteria. So I think those biomarkers are valuable to rule in diagnosis, but some patients can still have a normal DAT scan even though they turn out to have dementia with Lewy bodies. So it's not always useful as a rule out.
David already mentioned the REM sleep disorder. There are a lot of kind of clinical mimics, so you do need to be a little careful there. And I think the way to really do that is with a polysomnogram. So get them in for a sleep study. Usually has to be in a sleep center to make sure they're having the motor activity during dream sleep that you're not really supposed to have. Other proposals within the prodromal area would be things like having an increased risk for delirium in the context of another, say, medical procedure, and then early psychotic symptoms, particularly hallucinations. One of the questions is whether is to make sure that you're actually identifying those hallucinations in a way. And number one is just be sure you're asking. So a lot of patients are not necessarily bothered. It's a little bit odd, but are not necessarily bothered by the hallucinations. So you have to ask, and they say, well, yeah, I do. And they're not really bothering me, so I didn't mention it to anybody.
In this second part of the conversation, I hope we'll discuss some things that would help primary care physicians or other physicians in the community to kind of better recognize and detect patients who may be developing dementia with Lewy bodies. Just by, for background, and probably to underscore the importance of this segment, I know Dr. Galvin at University of Miami had conducted a study that identified half or more of patients who were diagnosed with dementia with Lewy bodies had more than 3 physicians along that journey before finally arriving at the correct diagnosis. And similarly, a study that was done in the UK had suggested that for every one patient who was diagnosed having dementia with Lewy bodies, there were probably another 2 people in the community who had gone undiagnosed. And so, those numbers, certainly underscore the importance of, having, heightened clinical suspicion for this condition. Maybe we could begin a discussion around some of the common clinical symptoms that a person might report to their primary care physician that should make them suspect dementia with Lewy bodies.
Yeah, because dementia with Lewy bodies has this really wide variety of core symptoms, you often hear bits and pieces of them depending on how they present. So they might come in saying they have memory or thinking problems, and it might be memory, but often they have more trouble figuring out how to do something that they used to do. Things are taking them longer. They're having more difficulty. And along with that, they have other features that you typically don't see very often in Alzheimer's disease. So that second thing that you can see is what we call Parkinsonism. So that's the motor slowing, sometimes a rest tremor, very slow movements, they're shuffling, they may have more trouble with their balance, they may have less facial expression. And this can range from prominent. So in my movement disorders clinic where I see people, those motor symptoms can be prominent, or in the dementia clinic where I see people, they could be so subtle that you really have to do, a lot of testing to pick that up. And then the other key things that you want to ask about are visual hallucinations, which we talked about before, but a lot of times people don't offer those things, so you really have to ask. You can ask about visual illusions. Do they mistake something for something else? The hallucinations tend to be fully formed people, animals, but they may start out more subtle. And then this suspicion for REM sleep disorder. So that's when you're acting out your dreams at night when you should be paralyzed and only your eyes move, your whole body is moving and acting out its dreams. They're often violent, fearful sort of dreams. And then some unusual things like I really stress to people to ask in clinic. So in our dementia clinic, this doesn't always come up, but the autonomic nervous system that controls your blood pressure can be affected and your bowel movement. So you can have constipation, you can get dizzy or lightheaded when you stand up, you can have urinary problems, sexual dysfunction. So all of those things are sometimes, it sounds like a lot, but those are the things that it's good to ask if someone's having memory problems to try to pick up some of those.
David, what advice would you give to a primary care physician who may have only a short time with the patient who's coming in and perhaps they complain a little bit of memory loss? What are a few quick questions you might suggest they could ask?
Memory loss doesn't always mean that someone has trouble learning new information. People say memory loss, but if you only have 5 minutes, just briefly clarifying what do they mean by that, and just follow up and say, do you mean that you don't remember conversations? Do you forget things? Or do you have trouble paying attention? Do you have trouble multitasking? Are you starting to get lost in places you normally wouldn't have? And those are the key questions that make them cue you in. There could be a problem with attention, executive function, or visual spatial perception. So that tells you this could be something other than Alzheimer's. When you look at them and you walk in the room, if that arm at rest is shaking, have them hold it out while you're talking. Say, hey, can you hold your arm out for me? And when the tremor goes away, and then after a few seconds it comes out again, that means it's a resting tremor that reemerges when you hold a sustained posture. Vast majority of the time, if someone has rest tremor and it's unilateral, that turns out to be a Lewy body disorder. Rarely it can turn out to be a close cousin like multiple system atrophy, but it is never essential tremor. So that is your big red flag. This is probably Lewy body dementia or Parkinson's disease with mild cognitive impairment. And those other screening questions that we heard about, it's important to have those top of your mind if it sounds like this is a non-amnestic form of dementia. So ask about, have you had hallucinations? It's okay, don't worry. I'm not trying to see if you're crazy or not. I'm just trying to get a sense if you could have a neurological condition that explains this problem. One thing that I recommend anytime someone with a memory problem or any feature suggesting anything in the Parkinson's realm comes in and says, I feel dizzy, or they recently fell, don't just ask them and try to figure out what type of dizziness they have. But if they had a blood pressure when they checked in, after you watch them walk down the hall and back, whip out that stethoscope and measure their standing blood pressure. If their blood pressure drops at least 20 points systolic, but the heart rate doesn't rise at least 10 points, so 50% of that drop, that is a big honking red flag. You're dealing with something in the Parkinson's realm, most likely Lewy body dementia if they already have dementia.
In a busy practice, it can be tough. You have your, 5 to 10 minutes, and you're walking in the room and the person's already sitting. Eye blink rate is another thing I tend to pay attention to. Another thing that I thought I might mention is just a lot of, I look at is the patient recognizing that they're having a problem? So that insight, a lot of Lewy body patients do recognize. They go, yeah, I get off track more easily. I'm having trouble from the sort of executive immediate memory sort of things. Classic Alzheimer's patients often say, no, my memory is just fine, and everybody behind them is shaking their head no. So that insight is actually one of those things I kind of look for, especially early to mid-stage. Lewy body patients often continue to recognize that they're struggling, which is a plus and a minus in many ways.
Completely agree. Kind of take us in a little different direction. Sarah, why is it important to establish an accurate diagnosis of dementia with Lewy bodies?
So clinically, I think it's really important, and I think families will tell you that. So because of this wide array of other aspects of their life that are affected that maybe you don't see so much in Alzheimer's, it's really important. And from a medical standpoint, there are some medications, for example, that people with dementia with Lewy bodies should never have, and they need to know because they can have very bad reactions to certain antipsychotic medications. You don't want to send them into the hospital without knowing, because somebody might give them one of these drugs and they can have a really bad reaction. So there's the medical side of it, and then there's the understanding, I think, of treating all those other aspects that we talked about, the dizziness when they get up, the constipation, the hallucinations, the dream reenactment, all of those things I think are really important to ask about and treat in a holistic pattern, because if they don't know what they're having, they sometimes, I think someone mentioned this, they feel like they're going crazy and they don't know what's happening. So knowledge is really important in terms of managing this.
Just in comment, I do think a lot of families, and it may be a bias within my own clinic, but really want to know what's going on. I mean, it's very scary not to know what's happening to, as you mentioned earlier, that the family is saying, this isn't like grandpa's Alzheimer's disease. This seems to be different in some way. So I think getting an answer actually helps a lot.
I'd like to maybe just turn a little bit towards, the more, I guess, clinically rooted question of, what are some of the earliest signs that a patient having memory complaints, what are some of the earliest clinical signs that you might detect that should make you think, this is the person that I need to take out into the hallway and observe them walk, or maybe I need to explore more about dream enactment behaviors or other parasomnias? If I were putting on my clinical hat, I would say, to David's point, that all the patients come in and they say, I have memory complaints, and it's sort of up to us as physicians to figure out whether memory is truly the problem or if they're really trying to express that they're having difficulty organizing their thoughts. Personally, when I start to suspect it's more falling into that, kind of difficulty with mental organization, or, organizing procedures in a particular sequence, that makes me start suspecting I want to ask some more questions around dementia with Lewy bodies.
I'll often go over the different kinds of memory with people and with their family members there and say, is this something where they get off track during a conversation? Or is this something where they don't remember, and even with hints, it doesn't come back to them about something that happened earlier in the day or a day ago, a couple of days ago? That sometimes helps them differentiate that. Again, I'd be interested in other people's opinions here. I also notice that in Alzheimer patients, you do see sort of delusional thinking. My brother, who it turns out has been dead for 10 years, visited me yesterday, and the family will say, yeah, that's a hallucination. It's actually really a false belief. And you really want to pin down that, were you there? And they said, yeah, there's a dog in the corner. you don't own a dog, or there's a kid over there. Those sorts of differentials can be very, very helpful in differentiating the hallucinations from other false beliefs, for example.
Yeah, that's an excellent point, and I think one that bears repeating, that difference between hallucinations and delusions, or the difference between hallucinations and illusions, or misperceiving things in the environment, can be really helpful. And as you mentioned, it's not uncommon that families might kind of describe all of those things as hallucinations to you, and only after you ask some follow-up questions do you realize, oh, that's more a delusion about, say, that somebody's been replaced by a reposter or something.
I think we see that a lot, that the hallucinations are mixed up with delusions, and it's our job as clinicians to really figure that out. And in addition to the other cognitive sort of thinking points that everyone mentioned in terms of distinguishing memory from sort of executive function, meaning figuring out how things are working or what they're happening, they might also notice some visual perception problems that they might describe as they can't see, or they can't see as well as they did, and they've been to eye doctors, or they are placing, missing things when they go to put it down. So those can sometimes also be, you can see that in certain forms of Alzheimer's disease, but we use that sometimes to help figure out some of the cognitive changes.
A lot of the visual variants of Alzheimer's, in fact, are Alzheimer's with Lewy bodies. So I think you're right that visual perceptual, that depth perception that people can really struggle with. It's commonly one of those early kind of visual spatial symptoms.
I think a challenge that I often see, even with neurology colleagues, is when they hear hoofbeats, they think about zebras. And what I mean is respect to autonomic symptoms. In particular, that orthostatic hypotension that I mentioned earlier. When someone has severe orthostatic hypotension, if they already have significant dementia, the vast majority of the times that's due to dementia with Lewy bodies and not multiple system atrophy. Multiple system atrophy tends to have an earlier age of onset than the other neurodegenerative illnesses, particularly dementia with Lewy bodies. So if you're seeing a much older patient over the age of 70 who has severe orthostatic hypotension and some cognitive issues, looking for evidence of clear cognitive impairment that interferes with everyday activities. So there's a question to call it dementia should steer you toward looking for the other features of dementia with Lewy bodies, and not to get down that zebra hunt of trying to call something that makes you think about multiple system atrophy the wrong thing.
So if you had a patient who presented with confusion and maybe some visual hallucinations, and you got the sense that it wasn't really memory predominant mild cognitive impairment, and when you ask them about dream enactment behaviors, their spouse says, yeah, that's been going on since we were in our honeymoon. Does the absence of Parkinsonian features, does that exclude the diagnosis of dementia with Lewy bodies, or is it that maybe not all patients have that?
I would say many patients don't have Parkinsonism at the onset. And I think, again, depending on your specialty clinic, if you have a Parkinson's clinic, of course, most of them do have Parkinsonism at the beginning. And if you're in a dementia clinic, though, we see people who may have very little Parkinsonism for a couple of years into the process.
The reason why we have 4 core features is one of them or 2 of them can be absent, and we can still make a diagnosis with a fair degree of confidence. I think one that we didn't touch upon as much, but really appreciate more the behavioral neurology perspective on this, is how do you like to ask about cognitive fluctuations? Because that's another core feature besides recurrent visual hallucinations, dream enactment behavior, and Parkinsonism, that I do have my own approach, but I think it would be helpful to really guide all of our colleagues. What are some of the best one-liners when we want to look for that feature of cognitive fluctuations that would help us make a diagnosis?
I'd say, do they have good days and bad days? Or are they pretty much the same every day? And often, if they're good fluctuators or bad fluctuators, depending on how you're tired, they'll say, yeah, some days it's like like he's back to normal. And other days he's really quite confused. And I can tell first thing in the morning, I've had some people say that this is going to be a good day or this is going to be a bad day. Alzheimer's, usually they'll say, no, pretty much the same every day,
The other one that I found really interesting is I'll ask about whether there are just spells of profound inattention or disorientation where you're talking to them, but nobody's home. And I'll often hear about or experience in my clinical follow-up several ER visits for a TIA with the exact same symptoms every time. And then they finally realize it's a cognitive fluctuation. I try to preempt that and warn them this is going to happen when I make a diagnosis to avoid those ER visits, of course.
Yeah, I agree. I think those are two really good points you guys made. One is that profound change. If they tell you that change in alertness, they just are staring off. But you can get their attention, so they're not happy, because it can be mistaken for a seizure, right? Staring off into space. And then the other thing that I think Jim mentioned, or maybe it was Brendan, saying that they're almost back to normal when they're having a good time. That's something you don't hear as much.
I certainly hope that this discussion can help some of our colleagues in primary care to, have a higher clinical suspicion when a patient is telling them about some of these symptoms that might not directly be connected with the memory complaint that they had brought up. Would you advise that, most or all of these patients should be referred to a neurology clinic or even to a specialty clinic for further evaluation and care?
I think it's helpful. And the reason, even my neurology colleagues who are not in movement or dementia will send, even my movement colleagues will send me people who have dementia with Lewy bodies, because there are so many different aspects of the disease that you're treating. And I think, being attuned to all of those, we talked about the prognosis, but you can really make a difference to quality of life, and by paying attention to those things. So I think it is helpful. And then, I think it's helpful for that reason, and to really firm up the diagnosis. Even if you have a question and you're not, some suspicion, we're happy to look at that. And then, as we go along and we develop better treatments and, if you're in a site like ours, that have bigger places and have clinical trials, those are places, getting somebody to that place allows them to have those opportunities as well.
Well, thank you, Sarah, Jim, David. I've really enjoyed having a chance to connect with you and talk about dementia with Lewy bodies. I certainly hope that everybody watching this segment has learned a little bit more about the disease, and as they go into their clinical practices, they not only have a better understanding, but a higher index of suspicion when patients are reporting some of those symptoms that we talked about.
Great. And on behalf of Cognition Therapeutics, I'd like to thank each of you. Hopefully this was interesting for the specialized neurologist as well as the primary care physician, individuals and families dealing with this devastating disease. Thank you.